Hello everyone, this is Victor from Victor's Portal. Nice to come your way again with a brand new tutorial on the top 10 challenges of in medical imaging. So what did I just say? The top 10. So in today's video tutorial, we are going to go through most of the challenges that are faced by medical professionals. Now they include your clinicians, your radiologists, and even from researchers as well, and why these challenges worth addressing, and how can you as an individual be a contributor, and at the end of the day we will wind up by looking at some practical challenges or some real-time challenges that are worth venturing into if you are a machine learning enthusiast, or maybe you're a medical image enthusiast, or even a medical image scientist. So now without wasting much of our time, come with me as we listen and understand this from the eyes of professionals. Now that means that we are going to look at mostly images. So our source of data will be purely images. Now I'm going to limit this purely to medical images. You might say there exist images, data sets in form of CSV files or .text files, or even some audio files and even some video files. I totally agree. That's why the caption says it all. So we are going to look at images, right? So you must have seen this most of the time. If you happen to be to the hospital, maybe for some reason, you might be asked to lie on this bed, and then maybe push you through this. Anyway, this is a CT scan machine. C stands for computed tomography, and then you will see maybe some visualizations here right away. And obviously you could see here maybe a kind of an MRI scan of the knee joint. Yes, I believe somewhere you'll be getting the kneecap here, and then these are all the bones, and then this might be some section of this is the cross section of the bones, right? So if you have been through this, then you must have been subjected to some modality in medical imaging. Hence, by way of definition, medical imaging refers to those techniques and approaches used to do what? Can I say recreate? Okay, so it is to create human or various parts of the human anatomy, right? Or an anatomical section of the human body, and for diagnosis, for prognosis, and for treatment as regards to what? Digital health. Now, having gotten a clear definition of that, let's look at more visualizations. So if you see here, this looks like some cross section of the human brain, right? And here is maybe a neurosurgeon trying to communicate his findings to his colleague. Maybe they were reading some of them, trying to understand what kind of ailment exists. Does this person have dementia? Is there any hemorrhage in the brain? What might be some of the conditions that this person is suffering? And how about the quantifying this in terms of the gray matter, the white matter, and the CSF? Is there any abnormality in this? And with that comes some modalities, right? Because when you talk of medical imaging, it is an umbrella term that includes various aspects of what the medical treatment. If you see clearly here, it includes various radiological imaging techniques, such as the most commonly used and available one is what we call your X-ray. Now, with more than 1 billion scans annually, medical chest X-ray, I beg your pardon, X-ray serves as a de facto standard for doing what? Understanding medical conditions. One, it is cheap, right? That means if it is cheap, it is affordable, and it is easy to come by. Just by standing in front of an X-ray machine, you could literally get your X-ray. It can be your chest X-ray, it can be anywhere, right? And followed by your MRIs, right? And then what interests me is what we call the ultrasound, right? Which we call ultrasonography, and endoscopy, tomography, and other non-functional imaging techniques such as your positron emission tomography or your PET. We also have SPECT, SPECT, and all whatnot. Now, the interest is not to look at most of the technologies. The interest is to understand the top 10 challenges. Now, here is the key, all right? So there are more than 10 of them, but I want to give you 10 plus 2. All right, so at the end of this video, you will not only learn about the 10 challenges, you will also understand ways to overcome most of the challenges, right? So come with me as we listen to some world-renowned researchers take us through this epic journey. Now, these are going to be 3 challenges here, and through the eyes of Ben Glocker, I want you to listen to him as he explains some of the challenges. Now, the 3 challenges here he highlighted includes learning the right feature, detecting when it goes wrong, and going beyond human level performance. All right, over to you, Dr. Ben.
While doing this, we also realized that there are quite some challenges, and I guess today there was already a lot of talk about different types of challenges. So I want to discuss 3 challenges that we saw in particular with respect to medical imaging. So the first one is about learning the right features, the second is detecting when it goes wrong, and the third one is how can we go beyond human level performance. So learning the right features might sound weird in a deep learning context because you would hope that your artificial neural network would just do the right thing, right? So you give it the data, you don't have to worry about handcrafting, designing features, you just let it discover the right features from the data.
All right, thank you so much, Dr. Ben. So as you could literally hear him speak, learning the right features here, just imagine that your problem is just to classify whether there is cancer or not. Let's take this classical example. The cancer, if there is cancer, then it is malignant. If there is no cancer, it is benign. And you have fed this through your deep learning models or deep learning architecture, and your model learned something like this, right? So your model learned that in real time, what the malignant cancer looks like is this with this color and this shape, right? And now when this was during the training, so the training was in a controlled environment, obviously. So you have cleaned all the data, you have done all the feature extractions. Okay, right. Now, if it is deep learning, it has to do automatic feature extraction. Now it has extracted this feature and it has learned that, yes, this is what it looks like during training. But now during testing, it now discovered that, oh, there might be variants of all this, right? So instead of me thinking that they will have this kind of color and similar shape, now I'm actually wrong, because this was what we saw during trade testing. Similar approach also happens when it is benign, right? So when there is no cancer, so you see again that this was what was learned during training, and this was what we learned during testing. Now this is a challenge because we know that most of our models that we create it under a controlled environment. Now, but during the time of testing, before we even deploy it, we now discover that if we feed it with an unseen data set, it's going to mess up the model. And these are now, he has highlighted 3 challenges, and now let's go through them one after the other. Learning the right features, we have seen that. Now let's move to the second one, which is what exactly, Dr. Ben, which is detecting when it goes wrong. Over to you, Dr. Ben. All right, so we are going to listen to Dr. Ben as he explains what he meant by detecting when it goes wrong. All right, let's listen right in.
What we are trying to do here is basically we try to figure out to automatically recognize when something goes wrong, but not on average, but on a per subject basis. So we came up with this framework, reverse classification accuracy, which is, of course, based on previous work on reverse testing and reverse validation. But really the idea here is to use this within the medical imaging setup, where we say there is normally some training data, some reference data, for which we know what the true labels are, at least the ones that we believe are the best possible we can get. Those are usually used to train a network, so you learn a system, you learn a machine learning method, a convolutional neural network, something that you can then deploy in practice. Now, on your new data, you get a prediction, and the question is, how good is this prediction? Every time you want to know, did it fail or did it do a reasonable job? You can use the prediction and train what we call a reverse classifier.
All right, so as you could literally hear him speak, in this case, when you want to dictate, how do you dictate when it has gone wrong? Now you see he started with our CNN, right? So this is the basic or the go-to method whenever we are working on images. So CNN works best when you have images. Now, no doubt about it. Now you see here, during the training, now we have fed it to a model, and then during deployment, now it predicted something. But we want to know whether this prediction was worth it, or do we need to refine this or refactor this, right? So now we have to do what we call reverse classification. So in the reverse classification, now this again, we send it back to the classifier, and instead of the training data becoming this training data, it becomes the test data, and you see the cycle continues. So now this has, Dr. Ben has addressed the second challenge. So what was the first challenge? Learning the right feature. That also we have clubbed it to what? Detecting when it goes wrong. Now the third challenge is going beyond human level performance, because we from the researcher's point of view, your interest is on quantitative data. I have seen lots of research work in which they use thousands or millions of data sets, and then they train that, and then trained and then deployed it, and they were able to achieve some accuracy. But from the radiological point of view, or say from a clinical point of view, now their interest is on qualitative data. Now it doesn't matter whether you got 99% accuracy, but their interest is why is it that you're not getting 100% accuracy. So can we actually come up with a classifier that will be able to perform or outperform human level intelligence? Over to you, Dr. Ben, as you take us through this.
Now, we already see there's a lot of talk about reaching human level performance in many parts. But the question is how can we go beyond what are the limit effects, in particular in medical imaging. Now, obviously, it's somewhere in the data that's generated when we say we have ground truth. We never have ground truth. We have something that an expert provided us. We try to find the best expert we can, but still, of course, there will be a lot of variation in quality of annotations. So they have to sit down and have this very tedious and time-consuming job of very detailed annotations in medical imaging.
Alright, so what are the two takeaways here? So if you want to actually compare this performance, the performance of our model, with that of human level performance, that means that you take a prototype of whatever your model performed or gave as an output, and then you compare it with that of what? A trained radiologist, right? So in this case now, we are talking about ground truth. So if you listen carefully, what Dr. Ben was saying here is that in the ground truth, we are actually asking question, how good is this model, right? So the ground truths are usually provided by trained professionals or trained clinicians in their field. If we are talking about maybe MRI of the brain, then we are talking of maybe neurosurgeons, trained neurosurgeons. Now those neurosurgeons, let's say we found 5 of them in the US, which are vouched for that they are actually the best in the US. And then how are we sure that those are ground truths? So what do you mean by ground truth? Ground truth is an expert knowledge annotated what image that says that this is exactly what the medical condition looks like. Now that ground truth, right, that was provided by them, I want to compare it with the one that was provided by trained neurosurgeons in London or in Canada. Now if there are variations, whom do we believe now, right? So there's also another approach which he didn't address, but I read that in a previous paper, where they actually bring those experts, clinicians together, they sit together and they brainstorm and come up with a kind of an agreed approach. Say if I have variations here and you have variations here, now we sit together and find out what the aggregate variation, trying to minimize what are misrepresentations. And this is what we're actually trying to do when we work on medical imaging. Now the question here is, can we synthesize, right? Can we synthesize a model that will be able to generate those ground truths, right? Or can we have a model that will be able to synthesize those ground truths such that, remember one thing here, that most radiologists or most clinicians, they are very, very busy with their work, right? As a research scholar, you cannot just approach them and say, please, I want you to annotate this for me. I want to know this. Even with collaborative efforts also is really difficult and time consuming. Now, just imagine they annotated only 10 samples of the MRI of the human brain, right? And now what I needed to feed to my classifier is about 1,000 of them. Can I actually synthesize those 10, right? So that I'll be able to get up to 1,000. Now, I'm not talking about data augmentation here. That's a different thing. Now, in this case, you see, it will consume lots of their time doing that. Now, and this is a challenge here. And there is a very good approach which Dr. Ben of Imperial College implemented, and I wanted to listen to him, where they developed a model where you can, looking at the edges, can you convert that edge into a ground truth? So let's look at it here, because there was a challenge here. He was able to replicate some human level performance of that, as in the case of cats. Though there are deviations, outliers obviously, where the cat had multiple eyes, right? But when it came to synthesizing the chest x-ray, right, that model failed. Now let's tune in as we listen to him take us through this journey.
The idea would be really, what if we could draw a manual segmentation label map and have a network that would produce us the corresponding images. Then we really have matching input and output data, and it could be considered ground truth. So this is work in progress. I don't know how many people have seen this last week or the week before coming up on the web, where people came up with a tool where you can draw outlines of cats, and it will produce you an image of a cat. So this is called Edges to Cats. Actually, I thought that's exactly what I would like to have for my medical image. So I want to draw something on the left, and I want to get a cat on the right. In my case, I want to get an MRI scan. So I looked at a few of those examples, and they're actually quite entertaining. And you see some nice results here, some not so nice results, some scary results. You might get a cat with a few more eyes here. And obviously, I was tempted to try this and want to get my medical image out of this, but it didn't really work.
All right. So let's be clear here. All right. So getting this synthesis as it regards other areas that has been researched upon, as in the case of maybe like classification, cat versus dog, handwriting recognition from your famous MNIST data set, that was pretty easy to do. But when you get into the anatomical structure of, or maybe anatomy of the human body, then you see it becomes really challenging. So far we have seen through the eyes of a researcher working in proximity with trained clinicians from Imperial College London. We have seen 3 challenges, or we have identified 3 challenges. Keep that in mind as we go to the 4th challenge. All right. So another area that is worth investigating is the work that was done by Prof. Terry Peters of Roberts Research Institute. As you can see here, he has highlighted 4 more challenges. That means that coupled to the 3 challenges which you've seen, which included what? Learning the right feature, yes. Detecting when it goes wrong, yes. And going beyond human level performance, yes. How do you cross-reference those images of the same patient? How do you rapidly integrate high-resolution 3D dynamic images? And how about what we call surgical guidance? Let's listen to him first, and then I will throw more lights on that.
So it matches to the intraoperative ultrasound. So one of the major challenges I see was some quite pedestrian challenges that prevent some of the stuff from moving forward as fast as it maybe could. Having all of the 3D and 4D data sets available instantaneously to radiologists and surgeons in the operating room or viewing room. Cross-referencing of images from one study to another study that might have happened a year, 2 years ago. Getting the same images automatically lined up. And exactly these points were made by Dr. Babin yesterday. Again, how do we rapidly interrogate a gigabyte of information, zero into the parts that are of interest, and then seamlessly integrating all these with the surgical guidance platform. And some sort of computational challenges, and I got these from a report that was recently commissioned by the Department of Energy and the National Institute for Biomedical Imaging and Biomedical Engineering. And these really gel with my view as well.
All right, so yes, let's now look into the computational challenges now, but yeah, it's also worth investigating, because let's say you are developing a multimodal approach, right, where you're going to look at varying modalities. So you have an image from an X-ray, you have an image from a CT scan, you have an image from maybe like ultrasound. Now, can we actually come up with a multimodal fusion approach where I can actually integrate most of these high resolution images into one? Now, remember here, the modalities are different, right? So images from a CT scan gives you a, what do you call it, a high dimensional view, right? Another challenge here that is worth mentioning is the work that was carried out by Prof. Christopher Lee of the University of Washington. This is in the US. Now, see, this was presented in one of the papers, which in one of the conferences captioned "Challenges and Opportunities for AI in Medical Imaging." Now, he's going to tell us, he's going to explain about difficulty in getting data, all right, and followed by extracting data for predictive analysis, and then he spoke about AI for diagnostic or for integrated diagnosis. Let's listen to Prof. Christopher as he takes us through this epic journey.
Volume, a lot of our time, radiologists' time is spent on non-interpretive tasks, like providing consultations, going into multidisciplinary conferences, scheduling exam, protocoling. And this has been compounded further by decreasing reimbursement. Radiologists are also concerned about their visibility due to the explosion in the digital technology. And all these factors are leading to burnout within radiologists. And this problem has been amplified with the COVID pandemic due to many pressures, including the pressure of finances, as well as expanded hours of service. So clearly, we will have to embrace more technology like virtual consultation, for using technology for multidisciplinary conferences, as well as education, and we have embraced some of these technology, but we need to build better platforms which enables a seamless deployment of our services in multiple different areas.
All right. So we just saw right now that it's very difficult, especially getting qualitative data. And he took an instance of the present pandemic which we are in which many of the radiologists and the clinicians work in isolation. So if really you want to kind of look into the aspect of precision medicine or personalized medicine, where you have to customize the treatment for a particular individual, that kind of data is not readily available. Now, the next problem here is extracting data for predictive analysis. Because from the researcher's point of view, you only want to know how you benchmark. Your interest lies mostly on benchmarking this data and seeing if you can actually turn your research project into something that is worth patenting, or something, or into a product which the world needs. Now, from the radiological point of view, from the clinical point of view, the interest lies on making accurate or quantifiable predictive analysis. Now, this is a challenge because it is not easy to come by, and let's tune in as he explains the approach in a while.
This is an AI tool to detect a pulmonary embolism, both in suspected but also unsuspected pulmonary embolism, which is quite common in sick patient and oncology patient. So these tools have been shown to be quite effective in detecting a decent sized lesion in different organs. The real value is not the diagnostics. I think the real value for AI in radiology is extracting data. As you all know, I think most of the radiology work is qualitative, interpreting images. But the real value is quantitating or extracting data. We use currently less than 10% of the data that is available for patient care. 90% of the data we don't know how to extract. And the data is in various forms, like body composition, like amount of visceral fat.
All right, so you had it all. That many of the challenges that we face here is extracting data for predictive analysis. In this case now, he spoke about what qualitative data, right? And that you remember here that he also explained that the difficulty in getting 100% of the data. That most of the time they end up using only or extracting only 10% of the patient's data. That the remaining 90% they don't know what to do with it. Wow, that blew me off because I never knew that this was also a challenge from the radiological point of view. Now let's go to the 10th point, which is what AI in integrated diagnosis.
I think this is another area where AI will have a bigger impact, and a high value indication for AI is integrated diagnostics. And what I mean by that is, as you know, each tumor is different, the outcome is different, and it is dependent on not only on the disease, but patient risk factors, lifestyle, the environment of the patient and the tumor. And if we can integrate all this information along with the lesion details to have a better idea of what is the likelihood of that lesion, even though small, that we cannot reliably characterize, we can predict better risk for treatment decision making, like in this patient with a chronic liver disease, risk for HCC, and so thereby facilitating right treatment.
All right, so you've had it all because yes, integrated diagnosis is something that is really challenging, because not only is it time consuming, again, it's also computationally intensive, right? So because of this now, let's go and have a quick recap of the 10 challenges, and you just stick with me for a couple of minutes as I'm going to show you some of the real challenges out there and how you can actually build some models, and you might even get some financial rewards in return. Come with me as we look into the next phase of getting a clear picture of how we go about these challenges. Can you kind of explain all the 10 points? Can you? And can you summarily tell me what you think might be an approach to them? All right, let's do this together. Now, you said that the first point was learning the right feature, which specifically revolves around getting the correct training data, right? As in this case, malignant versus the benign cancerous cells. Now, the second point, you guessed it right, detecting when things goes wrong. Yes. So, say we have built a model, right? And in real time, yes, it was working fine. But when we took it to a production site, when we noticed that it was really, really wrong, right? Now, in the sense, maybe our accuracy decreased to a greater extent. And that led us to the third one. Now that it has failed, now can we actually go beyond or kind of get closer to human level performance? Not even talking of going beyond that, because I believe this going beyond human level performance is kind of an exaggeration, right? Because this is talking about artificial super intelligence. We are still getting closer to artificial general intelligence. Now, going beyond human level intelligence, that is artificial super intelligence, which is a challenge, right? Even for quantum computers. Now, this is what Professor Ben of Imperial College London spoke about, right? So he said that this revolves around synthesizing the ground truth instead of relying on radiologists or expert clinicians, because we know that their time matters a lot to them, and also their talent also, and yes, it's computationally intensive for them to sit down and kind of give us all the ground truths, right? So if we can have a model, say we give an input and it to generate the ground truth, or it synthesize the ground truth for us, that is a very good achievement. And that led us to the fourth one, right? The fourth one was getting availability of what? Making available 3D and 4D data sets, right? Such that, say, surgeons in the operating rooms will be able to look at that data, and then we'll be able to understand in a glimpse what entirely has to be done as regards to carrying out some surgical procedure. Now, the next one is how do we cross-reference patients' data? Say, example, we have data from various modalities, right? And then we want to kind of make some predictive analysis on the patient's medical condition. Can we integrate this data, which is an approach called multimodal approach, right? Or multimodal, or kind of a fusion approach or multimodal approach toward medical diagnosis. And that led us to the sixth one, right? So the sixth one revolves around what now? Yes, integrating high-resolution dynamic images. Yes. So these high-resolution dynamic images, still just imagine here, I want to kind of reconstruct this. What am I reconstructing? Yes, integrate. Okay, there's a challenge which I'm going to talk about in a while. So maybe somebody is suspected to be having bleeding, which we call hemorrhage, right, in the brain. Now, we have taken various samples, various views of the brain, right, through an MRI, maybe the frontal view, the dorsal view, the lateral view, and all kinds of views, right? Now, after that, can we actually reconstruct this so that we will be able to quantify the shape and see whether there is kind of a rupture in the brain or something like that, a rupture in the vein, I beg your pardon, and then you see how the thing, maybe how the blood moves, right? And this will aid in what? Making efficient decision whether to go for a surgery or maybe with anesthesia or something like that. And that led us to the seventh point, which was what? Integration with surgical guidance. Now let's face this, all right? Would you as an individual be okay for you to be operated by a remote guided surgical robot? Let's be clear here, right? Now let's say you need to undergo a kind of an open heart surgery, right? take yourself as an example. Put yourself in their shoes, all right? And then this cardiac surgeon, who is standing. He's a human being with an assistive diagnostic tool, all right? Sorry, with an assistive model here, which is your cardiac surgeon, but he's a robot. The company tells you, the hospital tells you now that if this specialist cardiac surgeon should operate on you, it's going to take so much time, right? And it will cost you exponentially. Let's quantify this, maybe $200,000. But if you are operated by this expert system, in this case now, the robot, then it might cost you only a fraction of that, maybe $20,000. Now, which one will you choose? $200,000 versus $20,000. Now, if it's a matter of life and death, you have to choose $200,000. Why? Because we believe that, that perception is still not there, right? There is this misunderstanding between what goes wrong. What if something goes wrong here, right? So a robot is programmed to work like a one-way traffic. Now, are you sure this will be able to retract, right? And get back and correct whatever mistakes that it might make in between. So integrating this with surgical guidance is very, very difficult. What if the cardiologist is there, all right? So the cardiologist is there with you and he's saying, okay, I'm here with you, but without that human touch, right, you still feel uncomfortable. Hence, this is also a big challenge. Now that we have these models working, can we actually integrate this into surgical guidance? And that led us actually into another one, acceptability by the human populace, right? So that I did not touch, but that also is another thing, okay? And this is something that we cannot do without getting the right data. I saw a meme somewhere which says all you need is data, right? And another one says all you need is quality data. Now, mind the keywords here: data versus quality data, right? So you can get data in any form. Now, remember that your model is as good as the quality of data you feed into it, not the quantity of data you feed into it, right? So what we need now is both quantitative and qualitative data. Quantitative in the sense, if you want to address another difficulty, which is called algorithmic bias. I don't want to talk about that now, but here in that case, quantitative we need, right? And then qualitative is how good is this model? Is it devoid of outliers? Is it clean model? Is it clean data? Is it, can I trust this data? Now, because if I feed a wrong data into my model, obviously I'm going to get wrong output. So that's why we say, like, garbage in, garbage out. Good data in, good model out, right? Fine. Okay. Now, that led us to the ninth one, which is extracting data for predictive analysis. So this is much more self-explanatory, because from the radiological point of view, their interest is on qualitative data. But from your research point of view, your interest might be in both or even only on quantitative data. Now you see that this is a big challenge here, because if we don't extract those qualitative data, obviously we are going to end up getting what? A biased model. And the 10th one, right? So that is what AI in integrated diagnosis. Now, what do we mean by integrated diagnosis here? Now, this is not like surgical guidance where you have a physical machine operate on you. I'm looking at this, say, as you can see here, literally, this is the fundus image of the retina, right? Challenge which I kept here is what we call the data imbalance or class imbalance problem. Now, I have done a video tutorial on this, how we address this data imbalance problem. As you could literally see here, we have more samples of the blue data versus the orange data. Now, let's say here, this is more samples of normal patients versus COVID patients, right? Now, so in this case now, you have to make up for the stuff so that the samples are the samples are equally distributed, right? So we have like a kind of 50-50 approach or 60-40 approach, right? And there are other techniques, there are various techniques of making up for this data imbalance, which we call like data augmentation. Now, that is actually an add-on, right? And the next one is what we call public perception or public reception towards their health results. Now, this I cannot emphasize on it more, because just imagine that you have a model, right? And you are trying to sell that model to the public, right? So you as a researcher, you came up with a model that will be able to diagnose maybe autism, right? With some greater degree of accuracy. Now, you see, here the problem here might be acceptance, right? Now you said, see, this model, if you give me an MRI of this patient's brain, my model will be able to predict and give this. People tend to, if it is not diagnosed clinically, they will tend to doubt it, and they have genuine reason for doubting your model, right? Because this model can be highly biased, right? So you see, I keep using this word more often because algorithmic bias is a challenge which plagues virtually every aspect of what medical imaging. And not only medical imaging, whenever you work on machine learning project, you have to actually handle this. All right, so you have the model, it is working 99% of the time. Now, can you convince the public to take that? And what if it fails in real time? Because usually it will fail in production. All right, so public perception towards their health results has never changed. We have gone through most of the challenges, right? Most, not all the challenges. Now, you have made it thus far, and I want to take you to some real-time challenges that also gives you financial reward. Let's get there and you'll see that in a while. Now let's look at grand challenges in medical image processing. Now, if you go through this, you just type grandchallenge.org. Can you see here? Grandchallenge.org landed me to this page. Okay, grandchallenge.org. Now let's start from here. Here you see how you manage your data. You upload medical images easily and securely. You control what, blah blah blah. So this has to do with what? Getting quality data. Now, training expert annotators, right? This means what now? Looking at some features, right? How do you do your feature extraction? How do you identify prominent features? Now, how do you gather those stuff? And how do you benchmark it, right? So this has to do with validation. And how do you communicate your idea, right? Deploying them. Now, if you click on challenges, grand challenge, all right, go to challenges. Now you see there are about 259. Wow, yesterday it was 258. Now another challenge is added. About 259 challenges we have found. Can you see that here? 259 challenges. Now, the challenge that is of interest to me, I have opened them up here. All right, so the first challenge which I want to talk about is what? As it has to do with what? Ultrasound, right? So this is automatic amniotic fluid measurement and analysis from ultrasound image. Now, in case you don't know, now this is all about fetus, right? A developing embryo. I guess that's the right word, right? So in the womb of a woman, right? Now I want to know whether this is going to be a normal birth. Is there any problem? Is the baby developing normally, or is there an abnormality in this? Now, for me to understand this now, I need to quantify the volume of amniotic fluid in the womb. Now, you look here. They said participants can join any of the two teams. One team is all about detection, another one is all about localization. That means detection says here now that I want to know where the problem, I want to understand what the problem is. So you might do segmentation and then you'll be able to detect that. Now, localization is what? How do I narrow this down into a particular section? Say maybe this is where the head of the baby is. This is that. Let's identify all the internal organs. This is the liver, this is the brain, this is that, and okay, now all of them has formed. How do I localize this? Let's say at maybe like first trimester of pregnancy, right? Maybe around that 6 to 7 weeks. So this is a challenge, and you see here, it's called prenatal ultrasound, or US, okay? Measurement of amniotic fluid is important part of what? Monitoring whether the fetus is doing what? Thriving, right? So you could literally see, it says here, prenatal ultrasound measurements of amniotic fluid is an important part of what? Monitoring whether the fetus is thriving in what? Utero, right? Or uterus. Now, it provides a non-invasive way of assessing whether there is too much or too little amniotic fluid. You got the point here. Now, they see here, it says here, sonographic amniotic fluid assessment, right, can be performed on various ways. Now, the method currently recommended is semi-quantitative estimate determined by measuring MVP, which is what? Maximum vertical pocket, right? Now, what is the challenge? In this challenge, we ask participants to consider the problem of automated measurement of MVP using a predefined ultrasound video clip and based on a linear sweep protocol, right? Now, so you see here, this challenge is worth, I think, some thousands of dollars, and you see this challenge opened when 2020 and closed just maybe a March last 2 months ago, right? So, and then yes, and then submission date and results announced on the 31st or 30th March. So you see, again, detection and localization is also a major challenge here. But how do you detect if you don't know what exactly to look for, right? Another one that interests me is what we call what? Segmentation of multiple myeloma plasma cells from microscopic images. Now remember here, we are not radiologists. So we cannot deal with blood, right? We cannot go to that minute level of obtaining this. But when you are given a blood sample images of the blood samples, so you can actually make your predictions, train your model and get this. Now look here. Of late, efforts are underway to build CAD, computer assisted diagnostic tools for cancer diagnosis via image processing. Now you see here, now go there and go there. Exactly what is this challenge all about? Yes, it says here that such computer-aided tools require capturing of images, stain color normalization of images, segmentation of the cells of interest, and classification to count malignant versus benign cells or versus healthy cells. Now this challenge is positioned towards robust segmentation of cells, which is the first stage to build a tool for plasma cancer cell, namely multiple myeloma, right? Which is a type of blood cancer. Now, if you look at this here, you again understand that this challenge again is open to the public, right? I think when is the last day? Important dates here. Let's look at the important dates. So the important dates is 1st April. The deadline for the same is 1st April. Okay. I think submission of final updated papers with source code and this participant only 2nd April. Now challenge workshop of the conference will be on this. So again, it's done, right? So you see, these are challenges that you can actually leverage if you want to do a research in this area. Now, one thing before I go, which interests me so much, is this intracranial implant, all right, or intracranial implant. How do we develop a kind of an invasive technology whereby if we take an implant and cover, it should be able to fuse well, right? So it should be able to fuse, leaving no dents or leaving no harm after the surgery. Now you see here, he says, look at this, right? So let's understand what this challenge is all about. What is the task? It's divided into 3 tasks. So the task 1 is what? Now look here. Cranial implant design for diverse synthetic defects of unaligned skulls. Now you see, these skull defects generally occur at various positions with different shapes and sizes. In this task, the skulls were roughly aligned. You see here. So how can we align this properly? This is the first task. Now the second task is all about what? Look here. Intercranial or cranial implant design for real patient defects. It's called what? It's an aspect of medical surgery called what? Craniotomy, right? So it's a procedure of removing and replacing parts of the skull in order to conduct brain-related surgeries, such as brain tumor removal. Now, in this case of craniectomy, the bone flap is not replaced during the primary surgery and reconstruction is performed later. Now, often including what? In cranial implant design. In this task, 10 real craniectomy cases will be what? Evaluated. Now, for training, you can use this, and for testing, you can use that, right? Now, the task 3 is all about what now? Improving the model generalizability or generalizing ability for cranial implants. Now, let's say you have a model, you have created the model now. You want that model to generalize on, say, unseen sutures, right? Say this now is, you train it on this. But in real time, this is not how the skull gets fractured. It might fracture from the other side. It might fracture in a shape that is not even geometrically informed. Yes, it might be zigzag, it might be in any way. So you see here, okay, can come in different shapes, sizes, and positions. Now, besides being able to generalize across various skulls, deep learning model must also generalize to various defect patterns, right? So this is what we're talking about here. So you'll be giving downsampling the skulls to lower resolution can mitigate the general problem here, okay? Which is nonetheless not encouraged. So you need to work on the high resolution images without downsampling them. Now you can also augment this, which I spoke about in when you don't have enough data, right? Data augmentation, so that you create other versions of the same data, and you can use this shape trial of what? You can use a shape trial of the complete task which has already provided to improve your model. Now, after you have seen all this now you might be thinking, okay, where do I start from? Yes, you might actually start by looking at existing codes available online. So in the next video tutorial, I'm going to address that, right? Where do you get started working on this, right? We did all about Kaggle, and how do we do this? So now let's summarize. How did we start? So we started by having a clear definition, all right, of what? We started by having a clear model. We started by having a clear definition of medical imaging. Yes. Yes. After that, we saw various modalities in medical image, which includes what? Forensic, radio, X-ray, radiography, MRI, endoscopy, thermography, PET scan, and all what is right. And then we looked at what the challenges. Yes. So about 10 challenges we saw. These are the 5 of them, and then another one, and I gave you an additional 2, right? Thus far you have reached to this end. I want to thank you so much for your attention. So it will also be good if you could really like and subscribe to my channel for more interesting video like this. And feel free to get to the comment section below and share your thoughts on ways, maybe on things or aspects which I missed. And should you have interesting projects also or interesting challenges also, feel free to comment that in the link below. And then I'll be linking most of the resources which I use for the same. And in the next video, I'll be addressing how you actually overcome these challenges and where you get quality data sets for your machine learning projects and medical image related tasks. And we'll be looking at how you get started, because I believe one thing that is always good to stand on the shoulder of giants and try to kind of improvise on existing technology rather than reinventing the wheel. I remain my humble self, Victor, and thank you so much till I see you in the next video tutorial. Bye.